Most of the MBBS graduate, they want to go abroad.
There are a number of reasons, not just one.
Dr. Sudha Sharma, a renowned OBGYN, a former health minister, a former president of the Nepal Medical Association.
Our level of education is good. There's a lot of practical exposure because for those who study abroad, coming back to work in Nepal may be a bit challenging. So that is why most people come around retirement, but the practicalities of life kind of binds them.
Yeah.
And there's clear reasons. So many I have already cited. There may be many more, which makes them go abroad. So we really need to change that situation. As a result, the outpatients tends to get crowded, and the kind of patient that needs more care somehow tends to be missed in the rush. The commission part of it, you prescribe it, you will get rewarded for it. And then it is linked with, again, the low pay scale and, all the kind of thing that happens. So it's like a vicious circle, which we have to break, and we will.
What would you say to the younger generation of doctors?
To relook a serious planning of the entire workforce. That is what I would do as a number one priority.
Welcome to Chatter on the Streets. Today we have with us Dr. Sudha Sharma, a renowned OBGYN, a former health minister, and I could continue with all the accolades, a former president of the Nepal Medical Association, an author. And I actually want to dig in more into that, but I am so thankful for your time, and I want to dive right into some of the questions that I've been meaning to ask you for a very long time. So thank you.
Thank you.
Right.
Namaste.
Namaste. So just in general, you've been the health minister, and during that timeline, I just wanted to ask you, how do you compare, Nepal's healthcare to the international system across?
This is a very challenging question because comparing with international practices and Nepal sets the scene completely different from what you would get in a developed country. But having said that, as far as the standard protocols of treatment go, and the kind of response that people get,
right.
I think that's really good here in Nepal. Only thing where I would say we lack is the details of diagnostic procedures, as well as the time spent counseling the patient and giving treatment options so that they can decide for themselves. Like in the UK or US, a lot of time is spent on giving options to the patients so they can choose for themselves. Here, the patients will say, please do whatever is best for me. So as a result, doctors, and also because there's a lot of crowd waiting outside to be seen,
Yes,
in 1 hour time, we would see maybe 10 or more patients. So you have to be really quick. So the counseling part is not up to the mark here. I would have preferred to see more, but that's the reality.
What about the licensing process here? Because I've come to understand that as a DO, it's hard to get licensed here. Is that the truth, or what's your experience or knowledge about this?
Actually, we have a medical education commission which regulates the entire medical education, which conducts an entrance exam because we have thousands of students who pass the class 12 level, but then there are more limited seats in the medicine or other subjects.
Okay.
So they have to go through an entrance exam, and once they pass the entrance, then they naturally enter into whichever school they can get based on merit. Usually, you can get to choose the institution based on your merit. And finally, they complete their course, right, with the exams and everything. Once they've done that, there's the medical council, which also conducts a licensing exam. Okay. So you have to pass the licensing exam, which is pretty simple for the people who have studied in Nepal, but for those who study abroad, say in India or China or any other country, if they want to go abroad to study, first of all, they have to get a no objection letter from the government so that we know they're going to a valid a school which has been recognized for its credentials in the country. And then when they come back after their education is complete, they have to go through the entrance exam or qualifying exam of the medical council. And this is where people find it hard because although the curriculum is more or less standard, the way questions are asked or the way the students have been taught back in their colleges, I think that may be different. So many people don't qualify in the first attempt. So they have to repeatedly appear in those tests. So that is a challenge for those who study abroad.
Okay.
But for the people inside Nepal, I think yes, they do have standard rules, regulations, and credentials. And to be honest, our people, our doctors are doing good. The education level here is really good because most of these doctors they get employment just like that when they go out, like to US or Australia or Canada, wherever. So they pass the qualifying exam of those countries very easily, and they get to work abroad. So our level of education is good. There's a lot of practical exposure because the patient volume is high. But for those who study abroad, coming back to work in Nepal may be a bit challenging.
Okay.
Yeah.
Right, because I've had the opportunity to talk to some of the DOs and their personal experience here in Nepal, trying to get licensed. And somewhere there are so many obstacles that do you just get frustrated just because there are so many, there's a need for providers too in Nepal and just to mobilize expertise and, and as a DO. And so I was just kind of curious to understand, like, if we have something like a document that shows like the process, the step, is it digitalized? Like me as a nurse practitioner, if I were to come to Nepal to practice, like, is it even recognized? Because, if we're comparing, like, and I know you said something important before we started this interview was how is progress measured, right? Like, I mean, right now, we can't quite compare it to the States or other countries because we are just starting to make that progress. So maybe in 5, 10 years, we might see a different Nepal when it comes to approving certain licenses. But it's just like if India recognizes, US recognizes, is there a way to better facilitate?
I think in the past, NMC, the Medical Council, was recognizing most other degrees also, because at that time we didn't have as many human resource in the country as we have now. But as of now, we have a lot of doctors who are produced here in Nepal, and there's a challenge with the number of jobs available for them. So one of the policies the government has adopted is not to accept foreign nationals unless that specialty is lacking in the country. So that is why some of the Nepalese who are like abroad, but they would want to come back and contribute, they find it hard because they would have changed their citizenship and would be some other country's citizen. I think there have been cases where people have wanted to come, and we in Nepal, as policy makers, we have had consultations with the medical councils and try to facilitate, because ultimately they are non-resident Nepalese, primarily because of lack of job opportunities for the Nepalese who are in Nepal, and why would you give it to somebody else? That was the main concern.
Okay, no, I think that's a very valid point, especially because if we want to keep our providers here and employed, I think.
And also, our salary scale is so low, people who come from abroad, although there's a lot of rumor in the newspapers that people want to come and NMC is not facilitating. But to be honest, very few people come because, the salary
Yeah, the
is...
lifestyle. Yes, exactly. You get a taste of it.
little.
It's like your golden handcuff, right?
Yeah.
You do, yeah. But I think I've interviewed a few doctors that have returned back, and the primary motivator for that has been family, the cultural values of life, and just wanting to be near. And then it's like adjustments to like the cultural differences of like your education and, the practices you do. It's a big adjustment. So the licensing could be one. What else do you think might be a barrier? And the salary, yes, but if they had to, and that wasn't a problem.
And in constant touch with the government, advising in policy. Yeah. So I think there are good examples of what people have done, and I'm sure many other people could come and do similar things.
Yeah. So why is the trend then, like, most times, most of the MBBS graduates, like, they want to go abroad. Is it because we don't have enough specialties or jobs because it's saturated, right? Like if people want to stay within the Kathmandu Valley or within the major like metropolitan cities that we have here in Nepal, like who wants to go to the rural system, especially if you are married, you've got a family, you don't have the right education infrastructure. Is that one of the reason? Or but I've started to see a lot of that trend and it's been going on because, in the States, why can't we retain our graduates here if they wanted to?
It's not that 100% go. There are people who are retained in the country, but there are a number of reasons, not just one. First of all, now our production is at a surplus of what the country can absorb. So people go abroad. That's one reason. And like I said before, there are not many jobs in the government sector, because government also thinks, oh, there's a lot of private sector out there, private hospitals. Our policy is ultimately public-private partnership, so it's okay. And then government has to look after not just health, but so many others. Yeah. So creating a position means it's expenses, you see. So they want to cut the expense. So the opportunities in the government sector will be less. Private sector has become very competitive. And there's a lot of, in Nepali, we would say Shram Shoshan, which in English would be, you are made to work at a very low pay scale and out of compulsion because you have no other option, you would choose. And then the medical education itself, for those who have not got scholarships, there's a provision of 100% scholarship for almost, on an average, 30% of the entire medical seats, which is a huge number. But there are a lot of people who also study with self-finance. And that self-financing is very expensive, you see. So at the minute they pass out, they would want to recover what they have spent already. And that's also they need to make a living, right? Yeah. So that's another barrier. And the other barrier, which you have so eloquently highlighted, is the fact that they will be posted out in the remote. And usually those who study in scholarship, the government mandates that they work for 2 years in a remote area, and then they can do whatever. Yeah, because the government also cannot accommodate all of them in regular jobs. So at least 2 years, you are already working in remote. And when you work in the remote, you also get certain points which enables you to join the postgraduate course, again with scholarship. So it's a plus. If you have worked remote, you get additional points, which will enable you to get seats in the postgraduate. Because, as I said before, between ISC, which is the intermediate level education, and medical education, there's a huge gap in the number of seats. And between MBBS and post-graduation, again, there's a huge gap. Not all the MBBS get opportunity for postgraduate courses, you see, because the number of seats are limited. So what then do they do? They'll say, okay, my friends are going, everybody's going, so there's a lot of peer pressure. And then people go and they shine and then do well. And these are young people. Once they have kids, they start thinking about their spouses, and then the kids' future. And they keep thinking, oh, I have to go back home, and I will. But in that process, years pass. Then they say, oh, now it's too late. I can't adjust. And my child, is in a critical age where I can't leave. So then people will come when they're about to retire, when they have settled, when they have a regular income source, you have invested, and all the interest of your investments is giving you enough good, decent lifestyle here in Nepal, because life here is pretty good.
I would agree
You wouldn't like the atmospheric pollution or
the mechanical noises,
the contamination, the roads and everything, but it's home. You have family, then you have a support system. With very little money, you can hire, daycare and help and anything. So you are like a king here, like a prince, if you have, enough money. So that is why most people come around retirement, but the practicalities of life kind of binds them. Yeah. And there's clear reasons. So many I have already cited. There may be many more. which makes them go abroad, So we really need to change that situation and make the system here inside the bureaucracy. The bureaucracy is also quite cumbersome, So who gets posted where? And that transparency in posting and tenure-bound posting, that also doesn't happen. So even though you may be inside the system, first was not being able to come into the system. The second is the bureaucracy within the system also kind of makes you want to leave and go. So these are the challenges that young people, young doctors face in the country. And that applies to nurses as well.
Right, yes,
Yeah,
and that's
yeah.
just because there is a need, there's a healthcare gap, especially as we're talking about, Nepal transitioning into the least developed country to a developed country somewhere in November and we're going to have to deal with some of the consequences that come with that. And are we ready for it? Because we're going to see a lot of gap, right? And so it's like, how is Nepal training? Because I'm just thinking about the COVID times. Nepal played a pivotal role. And like, where are we since then? What other changes have we implemented?
One of the advantages, I would say, that COVID gave us was the upgradation of many, many facilities. This time, as a minister, I had the opportunity to visit all 7 provinces, and at least 36 hospitals I visited, even in a short period of time. And I could see that the infrastructure in terms of the beds, the equipment, and anesthesia, ICU, all of that has been quite upped, enhanced. So I think that was a blessing in disguise from the terrible situation that we had during COVID. But yes, improvements have been made. Theoretically, yes, we do hold the doctors to account, and I must be honest, the doctors do their best. But sometimes things go wrong, and that is primarily because the doctors are overburdened, and also I mentioned earlier this lack of communication skills. So the trust between the doctor-patient, that relation is somehow not strengthened. As a result, the disgruntled party then would go to whoever is listening to them. And nowadays many podcasters and many lay social media people, they are the ones who would then come and try to project that story out. So
the hyperbole that comes from it, exactly.
And from a very little incidence would be magnified to many folds, and that further, the fear-mongering part you just mentioned, that further scares the doctors, and they try to be more defensive and overtreat, or sometimes just refer if they see a challenge, So that's kind of a vicious circle which should not be happening. But having said that, this entire system of referral in the country is challenging. We have not been able to do that. And as a result, hospitals like Beer Hospital or Teaching Hospital or Patan Hospital, which are tertiary care referral centers, they are also practically serving like a primary care facility. Anybody just walks in, and then we have to provide services to them. As a result, the outpatients tends to get crowded, and the kind of patient that needs more care somehow tends to be missed in the rush. So we do need to develop a proper referral mechanism. We do have a program called MD in General Practice, So that's a MDGP program, which was actually designed for remote parts of the country. He or she can perform the necessary, say for example, C-section, or if there's a fall or something like a trauma or appendicitis or whatever, like acute emergencies. And if there's a theater, and we don't have enough of anesthetists, but we do have paramedics trained in anesthesia, and they are giving good spinal anesthesia, So with the support of these people, and now increasingly anesthetists are also being posted out in these remote areas where the operating theaters are. So that kind of human resource we have produced, and they've done very good job, especially in the past for maternal health. But in the recent years, they are also now being absorbed by many of the private medical colleges and private hospitals to manage their emergencies as emergency practitioners, because whatever comes in the emergency, if there's a higher level of doctor in charge, then he may have medical officers under him, but ultimately that MDGP is made in charge of the emergency. So the human resource, the scarce human resource that we had produced for remote parts of the country is now being absorbed in the large cities, managing emergency in many of these private hospitals. So that is the situation. So we need to improve that situation, have more systematic family physician kind of human resource that we have in other countries, and also strengthen our referral mechanism, that's for sure. And every government, including me in a short period of time, we have worked towards strengthening the referral system and making sure things are done in a proper way. But it takes time, it takes intensive resources and management skills. So it's an area where we need to improve a lot.
I think Dr. Prabhat Adhikari kind of mentioned this early on. It's like coming back to Nepal not as a job seeker, right? Because if that's the mentality, then it's not a place, perhaps. Because there's so much, like, when it comes to like the Nepal healthcare system, we're versions in many ways, right? And especially like in this area of like trying to mobilize rural health. Like we need that. And you mentioned earlier about like the surplus. We have that, but yet we don't, because nobody wants to go there. And I think it's like, what better incentives can we present these young doctors with so that they can go? Because it's practicing medicine. The more you experience and trying to meet them somewhere, because yes, they're spending a lot of money, right? And it's like funding an issue. Like, are we that poor of a country not to be able to pay our doctors enough so that they can at least go maintain a lifestyle that's decent enough, and so, right.
For the government, it's really challenging because the government has, in fact, spent a large amount of money to train these doctors for 5 years. And then covers their salary for 2 years. And when you're posted in a remote area, you get 100% of the salary as an incentive.
Okay.
And sometimes, if the hospital is making enough money, we do have a system called Aspatal Vikas Samiti, which is a development committee, which actually manages the hospital and is allowed to use the resources generated. So many of the hospital management committees are also giving them incentives, maybe 100% of the salary or 50% or whatever their capacity is. So these doctors in remote areas are getting 3 times the salary that a doctor in an urban area would get. But that is, again, not uniformly practiced everywhere. That depends on the strength of that hospital, the earning capacity of that hospital. And if the hospital is kind of well supported by the local government and has, a dynamic leader in place who can make change, then yes, those hospitals are doing good and they're providing young people with lots of resources as well. But that's not uniformly available. So making it available across the board, I think, is an area we need to look into and strengthen. Yes.
That sounds very promising, just to even know that you've implemented those, protocols as well. So I think it's just fascinating. I think of the resources Nepal has, and why don't we have clinical trials then here? Or have we ever done, and again, it's not like I've done my research here, but I was just kind of curious to know, pick your brain in regards to, does Nepal perform any clinical trials?
We have performed clinical trials in partnership with foreign universities, like the Oxford University or some universities in other countries. We do have a Nepal Health Research Council, which has its own standard rules, which allows clinical trials. But for human trials of different levels, that has to go through a process of government approval as well. But otherwise, for simple studies, there's the Nepal Health Research Council can give, their ethical board will review and then can give you permission to conduct those researches. But I think not we don't have as many research in clinical research in the form of clinical trials, but we do have operational kind of research, like programmatic research. Implement something, test it, see whether it works, and then change it. Like, for example, in our maternal health, initially we started with, just incentivizing women, giving them allowances to come to the hospital, like a transport cost.
Okay.
And then we said, oh, but our hospitals, our health facilities are not equipped enough. And then we had 90% were home deliveries, right? So, okay, then what do we do? Okay, we give incentive to the healthcare provider to go to their homes and conduct deliveries. So they get paid. The healthcare provider gets paid, and the quality of care would be better.
So it's sort of like a doctor on call kind of thing.
Infection prevention practices are maintained more, because otherwise they will be, the kids will be born in cowsheds and things like that. So that was practice. But then what we did a study to see whether it was working. Then we realized, no, there's a lot of women who were delivering unsupported, but healthcare workers were nonetheless taking money, saying that they're supported, or women who would come to, the immunization clinic for their children. Then they would get the details, fill up the forms, and without attending, they would say, okay, we attended, and they would take money. So researchers of that kind, and then we gradually modified. So. And then we also upped our, the infrastructures were upgraded. We created thousands of birthing centers in peripheral parts of Nepal as well. So now our institutional birth is almost at 90%. It still needs to be improved, but and the quality is an issue now. We need to, the number-wise, we've done well, but quality-wise, we need to do much more because our maternal mortality is still high. But what I'm trying to give as an example is the kind of research that we did, and we are doing. We are doing lots of research. Actually, Nepal is one of the countries which does a lot of these operational researches. You go to any international conference, the number of papers that come out of Nepal is a lot. If you just search the Medline PubMed system, then you Google and then you search.
Ophthalmology actually ranks a lot too.
And there's a lot of Nepalese research out there, and each of these universities and colleges, they encourage research. Government of Nepal through the NHRC encourages research. So it's not that we don't have, but the kind of research that we need, the rigor of science, I think that needs to be improved.
I feel like I'm the one learning here so much about this, so I'm really appreciative. I feel like sometimes there's this part of it's just the way it's been, or it's like the blame shift that goes on, especially when it comes to with the recent lead poisoning, with all these the allopathic or Ayurvedic medications. Who's regulating this? What is a solution that you think might be effective in promoting and ensuring that it's well regulated?
These issues are surfacing now. For even me, I wasn't aware that such a thing as lead poisoning was happening in the country, because our the bronze plates that we eat on, the nutraceuticals, and so many of the cosmetics and so many other things, which we were not even looking. None of our organizations were really monitoring them. So when I was the minister, I was minister for 5 months in the interim period before the elections were held. So in that time, my primary focus, I had set three reform agendas, and drug and medicine was one of them. So what I have said is, okay, and that's linked to our insurance program also, our health insurance was becoming unsustainable because it was very expensive. So one of the reasons why it was expensive was because the medicines were expensive. And one of the reasons why medicines were expensive were we were importing mostly, and the quality of national products, we were not really sure. So people were not really buying, the institutions were not really buying as much as we would have liked at a cheaper cost. So we said, okay, but why is it like that? So what I learned is there are something like 24,000 types of medicines out there in the market. And if we test even 10%, we should be testing 2,400. Yeah? But our annual testing capacity was just at around 640 or something like that. So such a
That
low
ratio.
capacity.
Yep.
So I said, no, we need to change this. So we need to strengthen our Department of Drug Administration to regulate all of the products that we just highlighted. And also we need to improve the situation of the lab. So I requested the government, and we have to go through multiple government agencies, including the law, the general administration, the finance, and finally I got approval for increasing the number of people in the Department of Drug Administration, in the Department of Medical Laboratory. And we need to improve the infrastructure of the medical laboratory. So in a short period of time, I could get a detailed project report to design a new lab so that we can have, improved drug quality assessment in the future. So the quality assessment begins right from the time the raw material is imported into the country. Because if you import raw material which is near expiry,
Yeah.
the drug you produced will be of not as good quality as you would want to. So it has to start right from the beginning, and then I talked to the drug producing companies in the country, and I said, see, if the government promises to buy in bulk, could you make it cheaper and of high quality?
Yeah.
So which sounds a bit paradoxical. Cheaper at high quality. How can that be possible? But then they said it's possible because all the marketing costs will be saved, right? So if the government wants to buy in bulk, so if you don't have to have those marketing expenses, then whatever is their profit they can take, and then they can sell the drug at the bulk to the government. So that plan now, the earlier part of that groundwork has been done. And I do hope the new minister will take this up and take it forward. The team in the ministry, the secretary and the administrative team, they're all sensitized. So I think going forward, we will be having a better drug regulatory system in the country and a better drug testing capacity in the country, which will then address the issues of, what are the type of, not just medicines, the devices that we use, all these nutraceuticals, the contaminations, and the chemicals and reagents and cosmetics.
There's going to be more of a systematic approach to all of this.
It will take time, but gradually it will be done. It has to be done.
Right. You take that oath to protect the people, right? But then at some point, there could be a malicious intent of like why you prescribe certain things. And so it's kind of like also having a system of accountability, like knowing all of this, and are we holding each other accountable when we intentionally know these products could be harmful and we're still prescribing. I think it's the prescriptive part of it that is more bothersome than something that's just out there. And so as doctors, like they're saying, hey, you should go do this, because there might be a disclosure of like, hey, you get a certain percentage, you're getting compensated for it.
The commission part of it, you prescribe it, you will get rewarded for it. And then it is linked with, again, the low pay scale and, all the kind of thing that happens. So it's like a vicious circle, which we have to break, and we will.
With all the things that you've said, what would you say to the younger generation of doctors, right? How would you encourage them in terms of giving them hope in this day and age, especially with the whole new political system that we are about to experience?
I think there's a lot of opportunities for the doctors here, because we do have the government system, which, although it is, it pays less to see all the remote parts of the country, see how, get recognized with your own country, see how people live, you feel so grateful for whatever life you have, because you can't go into a government system because of the bureaucratic processes for whatever reason. Then there's a private sector, then there's academic institutions. So there's lots of opportunities. And also there is postgraduate opportunity. In my time, there was no medical school here in Nepal. I had to perform really well and get a scholarship to study in India. When I came back, there was no postgraduate here. Fortunately, the Royal College of UK, had a exam center here in Kathmandu. I had to appear in that exam, and then fortunately I passed and I had to go. But in that process, I had to leave behind my kids, my family, my husband, and without family support, I couldn't have done it. So, but now there's post-graduation here in the country itself. So lots of opportunities, and if you have initial team of colleagues, you can all chip in resources and make your own hospital, your own private clinics. There are lots of opportunities, and there's a need also, And now gradually, paying capacity of Nepali people is also increasing, so you can do that. And also, I'm talking just about the allopathic system of medicine. In the homeopathic system also, or in the Ayurvedic system also, lots of Ayurvedic doctors in the country right now. And, all these wellness and yoga centers and retreats.
Like the concierge system
so
that we have.
all of that is also quite flourishing here in Nepal. So I think lots of opportunities, and I would really encourage the young people to be here. I don't say don't go abroad. I say go abroad because that gives you a bigger and better perspective to really understand the ground realities of the country. But and also it gives you some economic security, because ultimately you do need economic security for your children's education and for livelihood in general. So I don't say don't go. You need to go if you have to go. But there is in the country also, there's lots of opportunities, and yes, things are not perfect, but nowhere in the world anything is perfect.
One day to change something about the healthcare system in Nepal, and I know you've highlighted multiple important things. What is one immediate thing you would change?
Oh, that's a tough question.
I know it is, but I just want to see what would come out.
I think I would start from human resource.
Okay.
Because at the moment, a lot of our human resource is mal-distributed. Yes, we have enough, and we have enough production, but that doesn't get absorbed in the system. The one that's in the system is also not properly distributed. There is an anesthetist where there's no theater. There is a cardiac surgeon where there's no operating theater or no team. So things like that are happening. So I think I would look at the entire human resource spectrum and try and improve that to the best of my ability. And in that, we have to add certain ancillary supporting staff as well. Like we have a lot of equipment, but the team, the medical equipment maintenance team will be less. And even for nurses, they have many nurses have postgraduate qualification. We have produced postgraduate nurses, specialists in kidney or heart or whatever, maternal health, midwifery. But in terms of creating positions for them, we don't have. So they have highly qualified, but then they're still working in their previous position, which is not fair to them, not fair to the country, because we couldn't utilize the resource that we have. So I think the one thing that I would do would be to relook a serious planning of the entire workforce. That is what I would do as a number one priority.
When can I interview you next would be my next question, because I'm just enjoying this time. So I really, really appreciate it. Chatter on the Streets will be back if Dr. Sudha Sharma gives me more for time while I remain in Nepal, just so that I could pick a brain and get smarter. So thank you.
Thank you for your time. And after I finished my term as minister just last week, I am relatively free. I'm working on a book, but you can't write all day. So talking to you is a big, fun for me as well. Just reliving my entire life and recounting my experiences. So thank you for this opportunity, and you're welcome to come anytime.
No, seriously, thank you so much. And I want to pick your brain about your post-retirement plans next time when we get together. So thank you so much.
Thank you.
Namaste.
Thank you. Namaste.